65. But in the cases I'm going to present, only one woman was in her 50s when we diagnosed her. And 90% of ovarian cancers are derived from what we call epithelial cell cancer. And I'll touch base on that just so you guys get a good understanding of where that comes from. Look at that. So types of ovarian cancer, there's basically three major types. But the biggest one we're going to talk about today, with which all of these women had, is this epithelial ovarian cancer. It makes up 90%. There are different types of epithelial cancers, and it just kind of depends on the pathology. I do have a case on endometrioid ovarian cancer, but most of them are high-grade serous. Serous makes up 80% of the ovarian cancers. It's the most common one. And then the other ones going down the line are not as common. This cancer here is the one that we see, epithelial ovarian cancer in women over the age of 60. These other ones are in younger women. Again, they're so rare I've not seen any of those. So this slide you're going to see a lot. And the reason I put this up here is because it is broken down into epithelial, but when we go down on the types, over here at this type 1, this is what I want to focus on because these are more deadly. These high-grade serous carcinomas, undifferentiated carcinoma, carcinosarcoma, can have a genetic mutation called TP53. Now, I bring that out, again, I'm not being paid to bring this up, but we just have a new risk assessment, if any of you are available. This is, just started this. In fact, I actually did it on myself because I have so many cancers in my family, and I had another patient last week that we did it, but it is a blood test, and it checks for this gene. So if any of you in the room have a family member with ovarian cancer, I'm going to strongly recommend that you pick one of these up and consider getting the test done to see what your risk is. So the other thing I wanted to point out on the slide is now that we're the research going into this, we're realizing that these epithelial cell ovarian cancers are actually originating in the fallopian tube. So there's one case I'm going to present, and I believe the family does not know this, but I'm going to point it out that her cancer actually originated in the fallopian tube. So with that being said, you'll see this slide often just because I want to point to you that type 2s, these women do not do well. Over here, type 1, I have one case on endometrioid carcinoma. These women do a lot better, okay? All right. There's nothing on that slide. Okay, so risk factors for ovarian cancer. We talked about age, especially the epithelial. These stromal and germ cell, again, are much rarer, younger women. There is no routine screening. That's why it's so important to know the symptoms. We know risk factor of being an advanced age, family history. Now, early menarche and late menopause, they put that up there. Those can be risk factors. In one of the cases, especially Nadine went through menopause at 39. So that wasn't, why she got this cancer, we're still racking our heads on that one. Women who have never had any pregnancies are at a higher risk. Now, protective factors, we do know that birth control pills can protect women against ovarian cancer, especially at young age. Tubal ligation, I was trying to acknowledge that, and maybe Dr. Anderson, regarding the tubal ligation, is it because we remove part of the tube, or do you know the exact reason?
Yeah, and tubal ligations are done a couple of different ways. So if we lift the tube, cancers that originate closer to the uterus in the fallopian tube, they have a less chance of making their way down the fallopian tube into the ovary. A lot of people now, and this is what I plan to do too, is if somebody wants their tubes tied, then I just do a bilateral self-injectomy. So we take that entire tube out. So that does reduce the risk of ovarian cancer.
That's great to know.
Yeah.
It's risk reduction of getting that whole tube out of there, especially if they're not going to have any more children.
Yep.
Awesome. One more point I'm going to take home. Okay. And obviously, a hysterectomy with bilateral self-ovariectomy. I should say, Now, just because you've had a hysterectomy doesn't decrease your risk of ovarian cancer. There is a case, a lady by the name of Colleen Drury. Colleen Drury founded Colleen's Dream Foundation. Okay, this is why we have this fundraiser, because all the money that we earn for our silent auction goes solely to Colleen's Dream Foundation. And their purpose is to put those money toward an early detection tool and treatment for ovarian cancer. Now, Colleen had a hysterectomy, but her ovaries remained. She started having symptoms of gastrointestinal issues. She even seen her OBGYN, sent her to her gastroenterologist, did a colonoscopy, yeah, nothing. Finally, I believe she had a friend who was a nurse and said, come into the ER, let's have, do the CT. She finally went in. She had stage 3 ovarian cancer. She ended up dying from it. So hysterectomy, just because you've had a hysterectomy, does not completely decrease your risk of ovarian cancer unless your ovaries and fallopian tubes are completely removed. Okay, so the symptoms. I gave you a card. That card was in the pocket of my friend Nadine, who passed it out to everybody she knew. So this is her card. These are just something I try to pass out to all of my females in my practice to know the symptoms. And most women who come in, and again, we'll look at all these cases, will have at least one of these symptoms. The majority of them will have more than that. Some of them, no symptoms at all. The type or severity of symptoms does not reliably correspond to the disease stage. And I want you to remember that, because my stage 1 and 2 were highly symptomatic. My stage 3 and 4 were not. Okay, so women can present in a couple different stages. In this acute stage, this is the scary one. They usually have advanced disease. We might find a pleural effusion present. They might be short of breath. Pleural effusion is a collection of fluid in the lungs, and typically that's because the disease has metastasized to the diaphragm and creating fluid which can accumulate or is now outside of the body or outside of the abdominal cavity. Women who present with ascites, which is one of the symptoms that Nadine presented with, is not good. Abdominal distension. I found an interesting fact that 27% of women diagnosed with ovarian cancer had a DVT or a blood clot a year prior, within the year prior of their diagnosis. That's because cancer is hypercoagulable and women can develop blood clots. The subacute are the symptoms that you guys have on your card there. So how to diagnose it? First of all, pap smears do not diagnose ovarian cancer. However, I did find a study that showed that atypical glandular cells on cervical cytology have a 5.2% of some type of malignancy. And of that 5.2%, 5% of that, or 18 women, had ovarian cancer. So if we see that, we definitely don't want to ignore it as providers. We want to get them referred to Dr. Anderson and let her figure this out. So really, to diagnose it, the first thing, if we suspect, is we get an ultrasound. If it's bad enough, like in Nadine's situation, we'll just take them straight to CT scanner. And then other ways, from paracentesis, looking at cells. Once we are suspicious that this is an ovarian mass, then we add the CA-125. But the CA-125 is not completely diagnostic, because 20% of people can have an elevated CA-125 and it not be ovarian cancer. So 80% of women will have an elevated CA-125 with epithelial ovarian cancer. And then surgery. And surgery is quite extensive, from total abdominal hysterectomy to taking both of the tubes, the ovaries, and then doing some staging, doing lymph node biopsies if they can, mastectomy. In Nadine's situation, part of her colon had to be taken away, and she had ended up with a colostomy. Okay, so this is the CA-125. It's just a protein that's found in ovarian cancer cells, and it does, it's typically, in our lab, it's like less than 31 is considered normal, but it just depends on the lab. for this presentation, I have 46 up there. 46, I guess, is the cutoff, but typically less than 46, you don't have to worry about it. All right, so the stages of ovarian cancer, you guys have to memorize this because I'm giving you a test at the end. No, this is what the oncologists look at and the gynecologists look at, but I'm not going to go with that. I'm going to go with this guy, which is stage 1, 2, and 3. So stage 1, the cancer's combined to one ovary. 1A. Stage 1B, cancer is found in both ovaries. 1C, we have one or both ovaries, and we have some cancer cells that may be spilling out in the peritoneum. So we got a positive washing during surgery. Stage 2, the cancer there's an extension of the cancer to the fallopian tubes or into the uterus. And that can be A or B, depending on the extension. Stage 3 is we are now seeing microscopic spread to abdominal areas, the lymph nodes, maybe there's a tumor in the mesentery or omentum, and again, there's different stage 3, A, B, or C. Obviously, C is worse than A, okay? So again, these are huge stages, and it depends on the treatment, depending on the stage where the gynecologist finds it. Stage 4 is obviously outside of the abdomen, okay? So like we have an effusion, and now it's in the lung, or we have a lymph node that we palpated in the neck, which is the case that I'll present. Okay, so here we go. Stage 1, right on time, okay. All right, we're gonna call this lady D, okay? I don't wanna give her name out, so we're just gonna call her D. So, D came to my office in April of 2016, and she just came in for a routine checkup. She was 76 years old. She comes in for her high blood pressure, hyperlipidemia. She's a snowbird, so she goes down to Florida, comes back to see me spring, fall, before she leaves. And she said, I haven't been feeling well since Christmas. She said, I can feel something in my abdomen. It's hard. I'm getting full easier. My bowels are working fine. I don't have any urination symptoms, but I have this occasional twinge of pain in my pelvis. She had no bleeding. She had an intact ovaries and uterus. Everything was there. She had a history of tubal ligation, which technically maybe reduces her risk of ovarian cancer. Could not remember when she went through menopause, and there was no family history. So on examination, I had her lay down, and I was palpating her belly and listening to her belly, and I could hear this swishing sound. It's like, okay, well, sometimes we hear that aorta sound, but she had a true palpable mass that was so irregular, I could feel it all the way up to her belly button. Really, really hard. Not really tender. So I'm like, I can feel this. I can feel this mass. She's going to go straight to CT scan. So we went ahead, we got her scheduled, but my differential diagnosis, obviously at that time, we got a uterine mass, or ovarian mass, ovarian cancer, I do not know. So we got the CT set up. 3 days later, did a CT, which showed a large 13 centimeter complex mass. So 13 centimeters is a good size softball, maybe a little bit bigger. It was complex in her pelvis. Radiologists couldn't tell, uncertain etiology, but then also found a 6 centimeter mass in her liver, which is like, oh no, okay, 6 centimeter mass in the liver. When we found the mass, we did go ahead and grab that CA-125, and hers was not terribly elevated, 273. So I did get her sent down to Dr. Krotzler. He's one of our GYN oncologists out of Methodist. He worked her in within a week. He wanted to know what that liver biopsy, or liver lesion was. So he's like, let's get that liver biopsy, then we'll go from there regarding the next step of surgery. So she has the liver biopsy on the 7th of May, negative, which is good, completely benign. So then he does the surgery. He goes in, exploratory, takes everything out, does the staging. And her pathology came back stage 1A, it's in one ovary, but it was high grade. Serous was on that side of the algorithm there. Carcinoma of the right ovary, epithelial. She's like right there with everybody high risk, okay? So again, I pull this up because we've got an epithelial cell ovarian cancer and it's high grade. But it's a stage 1. And when we look at the stage 1 treatment, and again, this is an older slide, but the treatment of ovarian cancer at first diagnosis hasn't changed much as far as the chemotherapy. But I want to point out here for stage 1A and 1B, if it's a grade 1, sometimes just removing it and observing it. Grade 2, observe or consider chemotherapy. Grade 3, chemotherapy. She was a grade 1A, grade 3, high grade. She needed chemo. So stages C, 1C, and stage 2, chemo. Stage 3, 4, chemo. Okay? So my point is that stage 1, if it was on the other side of that algorithm, they might have just observed her. But because it was high grade, serous, she had to undergo chemo. So she underwent adjuvant chemotherapy due to the high-grade serous carcinoma and had 6 cycles of carboplatin and Taxol. So chemo is designed to destroy the cancer cells and shrink the tumors. These drugs are pretty standard, and the initial diagnosis, most women will undergo a platinum-based drug such as carboplatin or cisplatin and a taxane combination, or Taxol. Women with ovarian cancer will typically get a 6-cycle dose of chemo. 6 cycle doesn't mean I'm going to get it in 6 days. It doesn't mean I'm going to get it in 6 weeks. It means they'll get a cycle of chemo. One cycle is 3 weeks. 6 cycles is 18 weeks. So these women undergo 4.5 months of chemotherapy. And it's not an easy chemo. This is a really tough, nasty chemo. Here's her outcome. D is still living. She's currently 81. She finished a full cycle, full treatment, and only had 1 chemo round. I mean, went through the 6 cycles, did well. Her last oncology appointment was this spring. CEA 125 is still normal, and she's had no evidence of any recurrence 5 years out. She's one of my survivors. See, look at that. It's an origami. These masks make me dry along with my Claritin. Okay, stage 2. We're going to call her Lou. So, Lou presented like a month before D, and I'm like, what is going on here? Why am I getting these ovarian cancer ladies? So she comes in and she's not feeling well. She's got a month history of I just do not feel well. She's had some low-grade fevers, which is kind of odd, but I'll present another case with somebody who presented with a fever. She's nauseated. She has a fullness in her abdomen. She has urinary symptoms. I am constantly going to the bathroom. I'm more constipated. She's got bowel changes. She has poor appetite, so that has left her with a 15-pound weight loss. She still has intact ovaries and uterus. No history of tubal ligation. She went through menopause at age 50, kind of an average age. She has a history of a uterine fibroid in there, which is just kind of a benign tumor, and we diagnosed that a couple of years before, but no family history of ovarian cancer. So on her exam, we lay her down, and her abdomen, I can feel again this hard, palpable mass. And I'm like, oh, and it's about the size of a grapefruit. It's in the left lower quadrant, so down here, but it did extend up. I could feel it all the way over here. I was very concerned about that. Patient did not even know she had mass. She was maybe 200 pounds, not horribly big. Bowel sounds were good, no hernia. Because I felt that mass, I'm like, we're going to go ahead and get that CT because my differential that I told her, says I don't know if this is a bowel in that area, lymphatic, female, but let's get that CT scan and go from there before we get you into a surgeon. So she has a CT scan within a week, and it shows a very large mass appearing to arise from the uterus. Okay. It's measuring about 16 centimeters, so pretty big size, and it's increased. And so the radiologist is like, yeah, still could be very suspicious for a large uterine fibroid, but maybe more suspicious for now malignancy. No other findings were noted. So I sent her, within 2 weeks, we got her into a GYN oncologist, Dr. Rodenbach. Dr. Rodenbach is from Nebraska Medicine, so you're going to see that I don't have any preferences. It's like I talk to the patients, where do you want to go? So she sees Dr. Rodenbach. She undergoes surgery. Dr. Rodenbach agrees that we got to go in there and see what's going on. She has a total hysterectomy. They take her tubes, they take her ovaries. She has extensive adhesions. Adhesions are like spider webs that form in the abdomen. And so she's got a lot of adhesions in there. And the takedown is very long, very traumatic, and she has complications of extensive blood loss during surgery. As a result, they can't do the staging like they wanted to do because otherwise she would have died. She ended up getting 4 units in surgery. So they had to close the belly early, and they were not able to do an adequate staging on her, okay? So keep that in mind. Her CA-125 is not terribly high, it's 134. Her pathology initially comes back that she's got a grade 1 left ovarian and fallopian tube, well differentiated, endometrioid adenocarcinoma, right ovary, right fallopian tube, uterus negative. So technically that would put us maybe in a stage 1. However, she's diagnosed at a stage 2 because of the extensive adhesions, and they were unable to know what the lymph nodes showed. So she automatically, it's like, we're going to do a stage 2 on her. So again, she goes down here. She's got one of these endometrial carcinomas. So it's like, okay, maybe we have a little bit of room to breathe with her, okay? I don't know why I did that. Okay, so she's upgraded to a stage 2, which means we gotta go with taxane and carboplatin 6 cycles. So she talks with her surgeon, and she's like, yep, I'm gonna go ahead with it. She is started on chemo in May. She has 1 chemo dose, and it about kills her. She ended up in the hospital, severely dehydrated, just horrible reaction, and she said, no more. Because of my age, I'm not going to complete it. I don't want any more. And she sees the the GYN oncologist and a regular oncologist, and they're like, okay. So her CA-125 was done last 2 years ago, and it was 6. She's still living. She's a patient of mine. She's doing very well. She's 87 now, and she's had no evidence of any recurrence with 1 chemo, which is amazing. And she says, I don't want to see oncology anymore. I've lived a good life. If something happens to me, it happens. Stage 3. This young lady, we're going to call her by her name. I did get permission from the family. There she is. I love those curtains. Jane Getzinger, wonderful, wonderful lady. I truly miss her. Okay. Jane presented to my clinic in December 2016. She had some left lower quadrant abdominal pain. She was 70 years old at that time. She had been seen 2 weeks prior because she had a cough and a fever. She was given antibiotics, a little bit better. Actually, she had a reaction to that antibiotic, and then she broke out in a rash and hives. But it comes in because she's having this pain. She reports that her bowel movements have been variable, and she has a history of diverticular disease. We found that on a colonoscopy. She noted now that she's having this constant pain. She denied any fevers or chills at this time, no nausea, no vomiting, no urinary symptoms, just the pain. She had no bloating, no symptoms of feeling full. She had a family history though. She had a sister who was diagnosed with stage 1C, low-grade serous ovarian cancer 10 years prior, so in 2015, 2005, but she had a recurrence in 2015, but she was doing fairly well. So her surgical history, she had a tubal ligation and an endometrial ablation, and she went through menopause about age 50. So not a lot of risk factors other than the one sister. Her exam, she was soft. I could palpate a little bit of pain deep in the left lower quadrant, but there wasn't any guarding. There was no splinting, no rebound, no hernias, nothing else on exam other than, yeah, that hurts a little bit. So knowing that she had a history of diverticular disease and where the pain was, I'm like, I checked the urine, it was fine. Based on her symptoms, I said, you know what, Jane, let's just put you on some Levaquin, because this was on a Thursday. I said, I want to cover for diverticulitis, and I started her on an antibiotic. I said, call me on Monday if things don't get better, and then we'll consider a CT. So fairly straightforward. Nothing really in particular in her exam. I put this up because her pain was down here, and it states, different areas of the abdomen, we think outside the box, we think about differential diagnosis. And the most common one over there in that lower quadrant is a diverticulitis. Maybe ulcerative colitis, ectopic pregnancy, but not in a 70-year-old, maybe an ovarian cyst, maybe a urinary tract infection, which I looked at. But anyway, we treated her for the diverticulitis. So on Monday she calls and says, I'm not any better. And so I'm like, okay, let's just CT you because I want to see if we truly have diverticulitis. I can't see diverticulitis on an ultrasound. So I got to do a CT. So the CT, we do that on the 22nd, which I believe maybe been on Tuesday. Shows a complex fluid and tissue density in the left indexa, which may represent hydrosalpinx. I'll get to that in a second. The radiologist says, let's do an ultrasound and see what's going on. There's no diverticulitis. So that was my second red flag. It's like, okay, there's no diverticulitis. What's causing this lady's hydrosalpinx? And there was a small amount of fluid in her pelvis too. So I did the pelvic ultrasound as recommended by the radiologist. The ultrasound is showing bilateral left greater than right, adnexal tubular fluid filled structures which may represent hydrosalpinx. Hydrosalpinx, hydro is water, salpinx is your fallopian tubes, okay? So, swollen fallopian tubes. No other abnormalities. The radiologist says, just follow up in 3 to 6 months. I didn't like that. I'm like, this is not right. Hydrosalpinx is a condition that we typically see in younger women. Correct me if I'm wrong. Yeah. This is a 70-year-old lady whose husband has passed away. She's not sexually active. She, no indication that she would have pelvic inflammatory disease, an abortion, infection, childbirth, scar tissues. So this is just a picture of what hydrosalpinx would look like. So on that same day, I'm like, you know what? Come on over. I want to do a CA-125 on you. I'll get it covered. So she comes in that same day because I did not believe the hydrosalpinx. This can't be right. I'm gonna work this up even further. So I do a CA-125. It's elevated. It's 376. Not terribly bad, but I'm like, Jane, I really need a second opinion. I want you to see an OB or GYN oncologist. I don't know what this is. And we set her up with Dr. Rodenbach. She's at Nebraska Medicine. And this was, so one thing I want you to remember, so Jane was sick right before Christmas. We did a CT right before Christmas. She waited until after Christmas. And the reason I'm saying Christmas because I want you to remember Christmas. Because this family has to go through Christmas every year thinking about what happened at Christmas, okay? So she waits until after the new year and then has surgery on the 9th of January. Total abdominal hysterectomy, remove ovaries, remove tubes. We have her omentums removed and we began the staging process. Unfortunately, she developed some complications. She has some adhesions in there as well. She has a small bowel obstruction. She has to be readmitted, transferred. She just really had a rough recovery. And I think they had to go in a second time. This is even before we knew exactly what was going on. Did we do chemo or whatnot? But she has another one, second surgery within 20 days, or sorry, within 2 weeks of her first, because of a small abscess, which can happen. And she's placed on parenteral nutrition. She can't eat. And finally, she recovers and she goes home 14 days after her second surgery. Her pathology, this is where it kind of is interesting, shows left and right ovaries. Both are positive for high-grade serous carcinoma, with both fallopian tubes showing high-grade serous carcinoma. Uterus is positive for metastatic disease. Omentum, which again is this fatty little thing that protects everything in here. This is why we all have these little pouches, it's because of our omentum. That's the funny thing. Her omentum is positive for metastatic disease. Multiple areas. She has adhesions are that kind of scar tissue or spiderweb stuff to her anterior abdominal wall, positive for metastatic disease. There's a diagnosis comment, and I wanted to bring this up to the family member, is that on her right adnexa, there was a tumor focally involved obscuring the lumen of the fallopian tube. The tumor is favoring to represent a tubal primary with secondary spread to both ovaries as opposed to an ovarian primary. She had fallopian tube cancer as her primary. That's spread. Her diagnosis doesn't change anything, but she is diagnosed with a stage 3B high-grade serous ovarian cancer, not hypersalpingus. You ever seen that before, Doctor?
I've seen a case of it, not personally, but the gynecologist that I work with.
Hypersalpingus, that looked like,
Yeah,
and it was ovarian
described the
cancer.
case to me, yeah. It's not common.
Yeah, so, yeah, I went to the radiologist and even talked to them about it after we found out that she had stage 3 cancer, and it actually they reviewed it too and realized that, yeah, we probably should have mentioned cannot rule out rather than follow up in 3 to 6 months. So it was a teaching material for everybody and the radiologist, and you know, I've seen fractures on x-rays and the radiologists don't see them, and vice versa. I mean, we all work together. We want what's best for the patient. We don't want to throw anybody under the bus. You know, again, your gut instinct, I probably am overkill that I don't want to miss anything. So again, she has epithelial type 2 because we're high grade, and hers originated in that fallopian tube. All right, so her treatment, Taxol and carboplatin. So she starts her treatment, her first round of chemo. She starts it and does fairly well. She did meet with a genetic counselor. I tried to find that genetic panel, but I could not find it. But I did find that she was positive for a variant of what we call uncertain significance on her RAD50 gene. Now the RAD50 gene mutation is present, and that typically is a colon adenocarcinoma, lung adenocarcinoma, bladder carcinoma, endometrioid adenocarcinoma, and breast invasive ductal. Now, a pathologic mutation of RAD51C, we do tend to see that that is a risk factor for ovarian cancer, and women who carry that have about a 10 to 15% chance of getting ovarian cancer. That gene is included in the genetic testing that we have here. So just a little FYI. Okay, so here's her CA-125, again, her tumor markers, and this helps trend us, see where they're at with response. And she starts up here in the 300 range. She has her chemo in the spring of 2017.